This conference will now
There
be recorded.
are handouts with a little bit of fill in the blank if you want to take notes. Tammy, I sent those to you. So if you would help me distribute those as necessary, that would be great. So today we are talking about psychiatric medications. And the reason that we thought this was important is not to assume you guys are prescribers or need to know as much as a prescriber, but simply because things that you'll see are really important and you're the direct link, probably in a lot of cases, to the prescriber. So, okay, so let's just start. Hi.
Debbie, can you hear me?
Psychiatric medications. Psychiatric literally means mind changing. Okay, that's how it's defined. It alters or changes the way the brain actually works. Okay. So it affects what they call neurotransmitters in the brain, the communication between the different areas of the brain. Okay. So that's really important to know because different people will react differently. Different people have different functioning levels within the brain, and just the diversity of clients that everybody works with. You're aware of how that affects people. So,
hey,
okay, so we'll start with categories of medications. We'll start with antidepressants. Antidepressants, that's almost a buzzword.
Okay, that's good. Thanks.
Because depression is so commonly talked about. It is very universal. Oh, so what do I, here? Oh, bam. Hi, everyone. So we're talking about antidepressants. Very common phrase. Depression is a buzzword. Many people say I'm depressed when it's situational depression. So treatment with antidepressants, the common ones that you'll probably hear about are Prozac, Zoloft, Cymbalta, Wellbutrin. You know others. They affect the neurotransmitters in the brain, and they affect different chemical levels. Again, keeping in mind throughout this whole discussion of medication, different people are going to be affected differently. Okay. Usual response time for an antidepressant is 4 to 6 weeks if a person is going to have a response, which is a long time to tell a client that they might not feel the best. Okay. Often the support that you can give in validating someone's depression is going to help the process. Sometimes just by hearing, I understand you're depressed and this is coming, it can really help people to feel better. Almost like a placebo effect. But the medications themselves take approximately 4 to 6 weeks to get into the system. So just looking at these 4 medications, just a couple things about each one. So Prozac, it has a black label warning, which is not real common, but a black label warning is something that you really need to pay attention to as a prescriber. Prozac, the black label warning is behavioral disturbance, sometimes suicidal ideation, aggression. This is not common. It's not across the board with Prozac. So many people hear the word Prozac and they think trouble. Okay. It's an older antidepressant, but it's still pretty commonly used. If someone responds to Prozac, usually they respond beautifully to Prozac. Okay. Zoloft is much more commonly used, and general practitioners tend to utilize Zoloft pretty commonly. Very low side effect profile, fairly gentle on the system, really, but can take very close to 6 weeks to really get the full effect. Cymbalta is a newer antidepressant. It works not just on the neurotransmitters, but like other antidepressants on the serotonin levels, the chemical levels. So not only the communication, but the level of communication in the brain. Cymbalta is becoming more common. It is not a very frequently prescribed antidepressant with general practitioners. It's becoming more common with psychiatrists. Okay. And then lastly, Wellbutrin. A lot of people have heard of Wellbutrin as the stop smoking medication. And the reason that is because it does have some effect on the pleasure centers of the brain, which can be good or bad because it can be dulling to some people who suffer from depression, but it can be very effective. It's becoming less commonly used, but if someone responds well to it, they usually respond really well. So like I said, you guys know other antidepressants, okay? If you have questions about them, ask the provider. One of the best people to ask about medications is the client. Ask them what their understanding of it is, help communicate questions they have. Clients who are really proactive in their own care, they're going to pay attention to this. On the other hand, clients who are more histrionic or who tend to have some personality features might target, oh, this medication has these side effects and I'm having these side effects. So as we go on here, we're going to talk about how to evaluate side effects and just continued care for the client, referral to the psychiatrist. Okay. All right. So the second category is antipsychotics. There are two generations of antipsychotics. When I started in the field in 1988, there were first generation antipsychotics. The common ones were Thorazine, Stelazine, Haldol, and Prolixin. Haldol and Prolixin are still not uncommonly used today. The issue with first generation antipsychotics is the side effect profile is extremely high. Okay, side effects can include, sleepiness, sexual dysfunction, some cognitive slowing, dry mouth, urinary issues. So depending on the medication will depend on the side effect profile, but the overall side effect profile for the first generation antipsychotics is much higher. Okay. The antipsychotics for second generation are the newer antipsychotics, and they're called the atypical antipsychotics, and you'll recognize Abilify, Zyprexa, Risperdal, and in that category is also Clozaril. Okay. Those are probably the four most common that I could think of, and again, you guys are going to know other types of antipsychotics that your clients use. Again, your client is probably your first line information about medications. Just make sure you support it with collateral information, from other sources. So the thing about the atypical or the second generation antipsychotics, they tend to be very expensive. And there are fewer generic forms of these. Fewer generic forms of these. So, for example, Clozaril can be as much as $86 a pill. And, the pharmaceutical companies, that's a whole different issue. Some insurances do not cover these atypical antipsychotics. They'll say, use a Haldol or use a Prolixin just because they're much cheaper. There are, like I said, there are not a lot of generics available, so cost is definitely an issue. Okay. The nice thing about these new generation antipsychotics is the side effect profile is much lower. So you're not going to have typically the severity of side effects with these medications, and that's one of the beauties of them. Lastly, just one other thought about these second generation antipsychotics is often they are used in combination with other medications to what they call augment them. So for example, Abilify might be paired with an antidepressant to give that antidepressant a boost. Okay, that's not uncommon. Abilify is a more common one for that. So the atypical and the first generation antipsychotics, they're also used for dangerous behavior, and they're often used for behaviors associated with intoxication or acute drug reaction. okay? Hostility, combativeness, things like that. So a person does not have to carry a diagnosis of a psychotic disorder for these to be used. They're used in emergency rooms. They're used, when I was at Winnebago, we used them as just an as needed. If somebody was very aggressive, very out of control. So keeping in mind that they're used in acute situations as well. Okay. So the second generation antipsychotics, again, we need to pay attention to the fact that they're expensive. Often, I think you guys go to a lot of the appointments with your clients, is that right? So when you're in the psychiatrist's office, ask those questions. You know, how expensive is it? Is there a generic available? That's a beautiful question to ask, because a lot of times it's not really the doctor's role to say, oh, this comes in a generic, or, you know, they don't know what's covered and what's not. So it's really, really helpful if you guys ask those questions. If your client is not assertive enough or, you know, self-advocating enough to do that. Okay. So then there's the category of mood stabilizers. Mood stabilizers are used not just for bipolar disorder, like a lot of people think. They're often used in combination, again, with an antidepressant or with an antipsychotic for longer term stability. And I'll give you an example. Lamictal, lamotrigine, is a mood stabilizer that is very commonly paired with Abilify, which is an antipsychotic, okay, for mood stabilization over the longer term. Okay, so you're going to hear about these mixes, and if you hear somebody is being put on Lamictal, but they aren't necessarily bipolar, that's why, okay, because it's used to boost that other medication, okay. So lithium, very common mood stabilizer. You need to do blood draws to determine not just therapeutic level, but toxicity. Lithium is toxic by its nature. It's a metal salt, okay? So it is toxic to the system at high levels. And that's what it is. It is a toxic substance. So the blood draws, if someone does not cooperate with blood draws, it's going to be really, really important to talk to the psychiatrist, because the danger of toxicity is such that the person may have to be removed from the medication. Okay. So lithium, the big thing to remember is toxicity. There's side effects with lithium that I'm sure you guys are very familiar with: weight gain, dry mouth, sometimes urinary incontinence, sexual dysfunction. So you'll hear these complaints. Have them talk to the psychiatrist, or you guys address, you know, with the client's permission, these things in the visits. Okay. Releases exist for case managers and psychiatrists for a reason too, in between appointments. If you see something, if the client isn't willing to or able to call for themselves, please advocate for them. Okay. And we'll talk about how serious this can get in just a little bit. So Depakote, there's also a blood draw necessary. Depakote is not by its nature toxic like lithium, but you need to determine a therapeutic blood level. Depakote, once it gets into the system, like lithium, the blood level can vary. And you don't have to do anything specific for that to happen. It can be length of time the patient is on the medication. It can be, you know, systemic changes that the person goes through. It can be affected by health condition. And of course, you know, by adherence to the medication itself. So the blood levels are going to be probably just as important, but more so for therapeutic level rather than toxicity for that. Okay. So lamotrigine is a mood stabilizer that is really highly regarded at this point. It's called Lamictal as well. It's in the pill form. It starts at 250 milligrams, and there's 250, 500. The highest dose that I've ever seen is 750 milligrams. But again, that's individual to each person. The nice thing about Lamictal is the side effect profile overall is very low. However, initially when a patient is put on lamotrigine, very close attention needs to be paid of whether they have a reaction resulting in a skin rash. The skin rash can spread like wildfire and it can be lethal. So it's not common, but it happens. And so if a client is going to start lamotrigine, be eyes for that. When you have contact with the person, it might start on their hands, inside their forearms, and ask them, how you doing? Do you have any skin irritation? Things like that, because that's a really, really serious consequence of lamotrigine for some people. Okay, so then we look at the benzodiazepines or the anti-anxiety agents. These are contested and argued about, and points of contention for many people, providers and clients. Okay, so let me just start by saying some people absolutely benefit from these. Also, some people absolutely abuse these. Okay, and I think we've all had in our experience where we've been in contact with someone or we've heard about someone on both counts. Okay, so let's start with anti-anxiety agents. Anti-anxiety agents, by research supported information, are meant for short-term therapy, and that usually means 6 months or less. Okay, it's quite common for clients to be on them for years. Okay, and sometimes some of the thinking of providers used to be, and I saw this over my time working at the state hospital, is fear of the consequence of removing the person from it. Okay, not just physically but behaviorally. If a person, think about all of us, if we're convinced we need something and someone says we can't have it, how are we going to react? Right? Now add the component of addiction or obsession or personality features or histrionic, where I think something's constantly physically wrong. Okay, and other, there's a whole bunch of different areas where that could, be a part with the medical stuff. But just know that in order to be off of these type of things, a person really needs a lot of support. And it's going to show itself differently. If you are with a client in a psychiatrist's office and there's long-term use of anti-anxiety or benzodiazepines, ask why. Ask what the benefit is, but present it for your knowledge, okay? Not to challenge the client's status or why the doctor has kept this person on it for so long. Psychiatrists respond really, really well when you say, can you help me understand? Because they're the informant, okay? And they love, a lot of them just love teaching people. And so ask the questions. Real common benzodiazepines or anti-anxiety agents that I'm sure you guys have become very familiar with are Klonopin, Xanax. An older one is Valium. Very common is Ativan. Okay, Ativan is often used for acute behavioral disturbance, acute anxiety reactions, panic, things like that. It's not as commonly used over time as it used to be. It's extremely sedating, and it tends to slow the system quite a bit. Ativan and Haldol are very commonly used together for really acute psychiatric outbursts. And so you may see that or hear about that or see it in the record for someone that's at Winnebago, someone that's at Mendota. So don't be surprised if you see those two together. They've been used together for a long time. So Klonopin, you can easily buy Klonopin on the street. The going rate now is approximately $5 a pill, depending where you are. Okay, many people will get prescriptions for these substances And typically people who are not under psychiatric care, they'll get them from a general practitioner solely for the purpose to sell them and make money. Okay, so it's an actual active street drug. And that's important to know, because if a client presents with sedation or kind of inappropriate response to anxiety, stunted, it could be a lot of things, but talk to them, see what they're taking. It's more and more available than a lot of people think. And it's very commonly prescribed, very easily prescribed. It's one of the more commonly prescribed anti-anxiety agents. Okay. Primary care providers often will prescribe Xanax or Klonopin for people who are afraid to fly. Okay. They might give you 4 tablets, 2 for there and 2 for back. So just keeping in mind that there's a lot of different indications why doctors might prescribe it. But for psychiatric care and for anxiety, it is meant for short-term therapy. Okay, that's what research indicates. So Valium is more so than an anti-anxiety agent. It was indicated for anxiety in the 70s, very commonly. It's a straightforward tranquilizer. Okay, you don't see it as often anymore. It's used quite commonly in alcohol withdrawal, but often in the medical inpatient setting.
Why is that?
Because alcohol withdrawal is the only active withdrawal that will kill you. And
So
it slows down the body's acute reaction to the withdrawal.
Okay.
Because alcohol withdrawal is the only lethal withdrawal. If somebody is withdrawing from Xanax, they may feel like they want to die, but they're not gonna. And you hear people say that sometimes. So that's why it slows down the acute outburst reactions that alcohol withdrawal can cause. Okay.
Thank you.
Yeah, sure. So those are the benzodiazepines, or the minor the other ones are the considered minor tranquilizers, Xanax. So keep in mind, if someone is prescribed those, medication monitoring and supervision is huge for people who are prescribed benzodiazepines and anti-anxiety agents for obvious reasons. Okay.
Those can have long-term effects on slowing things down too.
They can.
I was on benzotropine when my sister passed away. And out of habit, you just get used to using that rather than making your own tools. So I had used it for a long term, and my speech and everything slowed down quite a bit.
It can slow your system down.
Yeah.
I'm venturing to guess it got better after you got off it.
Yeah.
And we'll talk about longer term side effects too, because that's a good point to come back to. Okay. So the benzodiazepines, the anti-anxiety agents, by their nature are extremely addictive. Okay. And keeping in mind that physical addiction and psychological addiction are both really big deals, and they're both valid. Okay. How often do I say I need something? We'll go back to that, and then have somebody tell me I don't need it. Okay. Even without physical addiction, the psychological attachment, the associations we make to substances, thinking even more commonly alcohol, okay, coping skill, that needs to be, you need to keep that in the front line, okay, because it is a really, really significant factor. So we talked a little bit about withdrawal from benzodiazepines and other anti-anxiety agents. You can see agitation, sleep disturbance, sweating, mood instability, irritability. So those are the most common, and the achiness in the muscles that can sometimes occur, it can be just really miserable. There's other drugs, of course, that heroin, your muscles feel like they're like tearing apart. And it probably, I don't know if it's to that level because I've never been through it, but I know muscle aching and tightness has been reported, and it's been reported in the research too. More commonly, you're going to see the agitation, the fidgety, the, impatience, irritability, things like that. Okay. The length of time it takes to withdraw from a benzodiazepine or an anti-anxiety agent, the answer is you don't know because people's systems work differently. And it also is based on the amount they take, the duration that it's been taken, the frequency that it's taken. Okay, so we don't know that answer. So keeping our mind open to that fact, it's going to take really as long as it takes for the client to really not just report, because reporting isn't always reliable, but to present with being at a level of more comfort or increased comfort. Does that make sense? Okay. So we talked about alcohol a little bit. There are medications that I didn't list for addiction. Okay. Methadone, very commonly used. Methadone clinics, also very commonly abused. Mm-hmm. What other medications for addiction or withdrawal do you guys see? Suboxone is a really, really commonly used opiate medication. It can reduce cravings. It does not cause adverse effect, like say Antabuse did.
I've heard of people snorting it too.
A lot of these can be taken in a lot of different forms. Most commonly, it's going to be the pill. I work at an outpatient clinic where there's a Suboxone provider, and the urinalysis and the blood draws and the compliance, is checked so frequently. And if in that agency, if someone is found to be misusing it or taking it in larger amounts at a time, it's ended like that, which means what's going to come?
Withdrawal.
More severe withdrawal, right? And that is at times a deterrent for people and what helps them stay compliant with Suboxone. There are also medications for alcohol. Does anybody?
I've heard of one where it can make them puke if they drink it.
That's the Antabuse often has a physical effect. That's an old one. There are some others that they're very new. Okay, someone may know, what they are. The important thing to realize is that to prescribe these medications directly related to substance use or addiction, a doctor needs a special qualification. Okay, and it's in the area of addictionology, it's called. So an MD without that qualification cannot prescribe Suboxone. Okay, a psychiatrist with an MD without that qualification cannot prescribe Suboxone without either a high level of supervision in the process of getting that qualification or having it themselves. Okay, so if someone is a drug addict, say with opiates, and they have mental health issues, it's going to be hard to find a psychiatrist that can deal with both. They're just not that common. Okay, and the shortage of psychiatrists in this day and age reduces that pool, which is frustrating. Okay. Okay, so there are medications that are used for multiple things. Okay, we talked a little bit about Abilify that is often paired with, say, lamotrigine, to help longer-term mood stability. A very common sleep aid is trazodone. Okay, some people don't realize that trazodone is an antidepressant, and so it's much more commonly known as a sleep aid, but it's got the antidepressant properties that really have been shown to be effective. So when you hear about trazodone, don't just think about sleep. Think about mood too. Okay. The issue with trazodone is it is so highly sedative. Everybody's system is going to handle it differently. Some people at a starter dose can have incontinence in their sleep, during their sleep. They can have clouded thinking, even hours after they wake up, where other people at much higher doses, they go to bed, they sleep through the night, they're up and ready to go. So a person's system is really going to determine reaction to any medication. Okay. So that's why you guys can really be the eyes and ears. Okay.
Some of the antipsychotics will do that too.
Oh, a lot of them will. Yeah, the older ones, the first generation ones
Yeah.
are often the most sedating and slowing. But absolutely, absolutely. So we talked a little bit about augmenting the medications, pairing them for better effect. And let's kind of shift and look at side effects. Okay. I had a doctor tell me once that there is not a medication prescribed that does not have some kind of side effect. And I said, well, antibiotics don't. And they said, have you ever taken an antibiotic and gotten a yeast infection?
Yeah.
I mean, seriously.
All the time.
Yeah. I
It's
mean,
horrible.
medications have side effects. Some are more overt than others, but just know that going in. Okay. A lot of them may not be real evident, but you'll see them in snapshot situations. If someone is doing a fine motor activity, you might see it. Or if someone is trying to process a complicated problem, you might see it. So we'll just go through a few, okay? So the older antipsychotics, most commonly the sedation, the tiredness, the slowed thinking, slowed gait, movement, very common. Back in 30 years ago when I started, it was very common that people would say there was such a thing as a Thorazine Shuffle. Because
Prolixin, the shuffle.
the system can be slowed by Prolixin. The Thorazine Shuffle was very specific because it was very difficult to lift your feet off the ground. So when you guys are wearing bedroom slippers and you tend to go, that's what it looked like. And it wasn't just because a person was lazy and didn't pick up their feet. It's because they leaned forward a little more, and so the feet kept contact with the surface. So that was a common condition that was often labeled with Thorazine. Looking at
I've had a few
Prolixin.
people with Prolixin that had a shuffle, like they'd be standing there and they couldn't just stand, they had to keep.
You mean the restlessness?
Yeah.
Okay, so with Prolixin and Haldol, and we'll talk a little bit more about this, there's a side effect that's called akathisia, and you might hear that word. And what that means is things like extreme restlessness, inability to sit still, fidgeting, okay? Somebody can't sit still in a chair, or they're standing and they're back and forth from foot to foot.
Yeah.
Okay, that's called akathisia because it involves physical movement of the body in restlessness. Okay, there's a different kind of movement that we'll talk about in a minute. Okay, so there's Parkinsonian side effects from antipsychotics and tranquilizers, and that's where you get the tremor. Okay, the shakiness in the hands, in a little bit in the limbs. That comes with slowed movement, which kind of seems like a contradiction, but you'll see both. When a person's hands are trembling or shaking, they may try to move their limbs to kind of dispel the shaking, but you'll see that they have to move it slowly, okay, and kind of very mindfully. It's ongoing though. And you can't just control it by closing your hands, or, you can still feel it. It's a feeling of just tremor, okay? There's also muscle rigidity. That's a common side effect of antipsychotics. And by muscle rigidity, the person feels like their muscles are almost like a solid substance that is fixed, okay? There's a test that is done often by the nurse or the doctor, and it tests what they call cogwheeling. And this muscle rigidity, have you guys heard of cogwheeling at
The
all?
one where they like push.
Yeah, if I take my arm and put it like this, and I've got that muscle rigidity and that cogwheeling, when I bring it down, it's gonna feel like a cog. It's gonna feel like click, 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 click. And that's actually what it's gonna feel like. Okay, so when the doctor or the nurse feels that, they'll know that that rigidity is there because it can't be prevented. Okay, if I bring the arm down, it's not like sometimes it's going to be smooth and other times it's going to be like a ratchet. Okay, it's going to be there. If a client says, I feel stiff, I feel tight, listen to that. Okay, so the other one is called dystonia. And when you're looking at dystonia, you're talking about pain. Okay, it's painful. People will have involuntary muscle movements in their face, their neck, their jaw, and it's movement in all different directions. Okay, there might be contortions of the face, there might be movement of the jaw back and forth or up and down, or you may see someone go like that. Okay, it's very painful, okay, to have that side effect. And so it's really, really important that you're sensitive to that, okay? Any of these side effects, it's really important the doctor knows. And it can be reported by you. The doctor will always ask the client their perception of it, okay? It's at different levels, but none less valid than the next, okay? So when you're thinking about dystonia, I really want you to think about physical discomfort because it can be very painful.
How does that differ from dyskinesia?
We'll talk about that. Tardive dyskinesia. Tardive dyskinesia is a full movement disorder. It can affect not only those areas, but the arms and the legs and the shoulders and the head.
So dystonia is more just localized.
Dystonia is preventable, and if someone is experiencing it, you can treat it. Over long-term, tardive dyskinesia can become permanent. So that's the big difference. It looks very different. It really does look different. Tardive dyskinesia, if you think of it's facial movements, but you'll see the tongue move very commonly, where with dystonia, it's often muscular kind of movements in this area or in the jaw. Tardive dyskinesia, you'll see rapid tongue movements or clicking. It'll be like, you might hear that. So there's also a writhing that can come in the shoulders and the arms. Somebody might roll their shoulders or stretch their arms like this. It's because they constantly feel like they have to, okay? So long-term antipsychotic use, that can become permanent, okay? So then you got a whole different host of problems, okay? You've got work performance issues, you've got social rejection, huge factor when things like that are going on. People will take a step back and people will question that person. They may just avoid them altogether. There's judgment and stigma involved, okay? People are going to make assumptions, and 99% of them are going to be inaccurate, okay? They may assume that the person is disabled to the point where they, can't engage like a quote-unquote normal person, okay? So be sensitive to that and be aware of that. Socially, occupationally, huge, 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 okay? As a result of that, people that suffer from tardive dyskinesia very commonly become clinically depressed. When these symptoms become permanent, it's almost like being locked inside your body and not being able to control it, okay? It's the movement side of paralysis when it's permanent. Does that make sense? it's like you're trapped in that condition. And again, I can't say what it's like. I don't see anyone sitting here that could really report what it was like, so the client report is going to be huge. Okay. It's disfiguring. It can really be disfiguring. If the mouth and the tongue continue in movement, it's going to affect the structure. Okay. You can get jaw lock. You can get all different kinds of things that occur over time. So it can be physically disfiguring. Okay. So keep that in mind as well. Now, there's one beyond that yet that's called neuroleptic malignancy syndrome. Okay, this also comes from long-term antipsychotic use very commonly, life-threatening. It can kill a person. Okay, I saw it at Winnebago, and it needs to be really quickly addressed. The issue with it is you're going to see rigidity in the muscles, so you might assume it's something else. You might assume it's tardive dyskinesia. You might assume it's the start or the outcome of akathisia, that movement. Often they will spike a temperature of 104 degrees or in that area, give or take a degree lower, but pretty close to 104 degrees. There's going to be reduced alertness, which can often be mistaken for dementia-like symptoms. Is the person on the progression toward Alzheimer's? Are they confused because of their medications as a side effect? So the danger with neuroleptic malignancy syndrome is that people very commonly assume it's something else. Okay, but you'll see it over time. There will be balance issues. There will be communication issues, and it's going to occur faster than, say, a dementia would progress or Alzheimer's would progress. Okay, and it's all ages. I've seen it in 20-some-year-old clients, and I've seen it in 60-year-old clients. Okay, so don't think that it's just locked to an older person who's been on treatment for years and years and years and years, or that it's just limited to Prolixin or Haldol or Thorazine. Okay, those are the more common ones. But even the antipsychotics that are prescribed now, when a person is switched to that, you're still on that type of treatment over time. Okay, and long-term treatment is what's going to be a trigger, okay, to the system. The other thing too is that with neuroleptic malignancy syndrome, you're going to see a reduced reaction to pain. Okay, where something might cause me pain, it may cause little or no pain to the person. And so that is something to really pay attention to, because the diminished reaction to pain it's not common. I wouldn't say, oh, that's a side effect of an antidepressant, or that's something it gets your attention. Okay, so that is often very specific to that syndrome. Okay, and does not involve mood disorder, mania, acute psychosis, because you can see that then too. Okay, the reduced reaction to pain. Does that make sense? Okay. So a big thing to remember is that case manager, social worker, nurse, group home staff, it doesn't matter. Anybody who is involved in the care of a client is the eyes and ears. Okay, so pay attention. Pay attention to, how does somebody walk to the table for breakfast? What are they complaining of? How is their sleep? How do they communicate with you? Do they communicate differently a month after you meet them, or 6 months? Are the families communicating concerns? What's in the record? Pay attention to what's been documented already. Then you don't have to recreate the wheel. And always ask the client what their experience is. Is something bothering you? Are you having any side effects? For a client to know that It has to be learned. Okay, so just like we need to learn what the side effects are of medication, the client does as well. And everybody has a right to know those. Okay, saying that, your involvement in helping people not assume they have all of them is going to be important. When I was in graduate school, they put the DSM in front of us and they said, you guys are going to think that you have symptoms of at least 5 things you read in here. And that's just because of association we make in a category. Okay? So if I tell someone you're going to have, a side effect is blurred vision, which can come from lamotrigine, or dry mouth, which can come from an antidepressant or an antipsychotic, or he might have trouble, avoiding going to the bathroom. There's a few that people may pick up and say they have when indeed they don't. But keep in mind, it's real to them. So through education, you can educate and help dispel that a little bit. A lot of times when somebody says they're suffering a side effect, the underlying factor is anxiety about being on the medication. And are you sure this is the right medication for me? And I'm kind of communicating like what the thinking might be. Not for everyone, of course. But if I say I'm having a side effect, I might be afraid of getting that side effect, or I might be experiencing it really, or I may be unsure that this is the medication for me, or I may not know really what the side effects feel like, or I may have heard from someone else that this side effect is just terrible when my system may react completely different to the medication. Okay, so it is an inexact science. Okay, if we watch TV every day, you see psychiatric medications advertised. Think about a sleep medication like Lunesta. That's used in a psychiatric environment as well. It's by prescription. People use it in the privacy of their own homes, even when they're not diagnosed with a psychiatric illness. You need to keep in mind how the marketing presents these medications as well. A client may say, I don't want trazodone, I want Lunesta, because the commercial has the free floating clouds and the pretty colors, and that's what marketing is. Okay, if I think that I'm going to sleep peacefully and count sheep, okay, rather than have a hangover in the morning, which one am I going to ask for? Okay, and the same goes for antidepressants. There's antidepressants of the day. Okay, someone may respond really well to Prozac, but they may say so-and-so took Prozac and they were suicidal. Okay, so that's where teaching and support is going to take another role. Okay, the more informed you guys are, the more help you can be to your client. Never having the client assume you know more than their doctor. If there is a question about a medication that even for a minute you're not sure, you say, we need to talk to your doctor or a doctor. A beautiful source of information is also the pharmacy. That's what they do. Okay, so utilize the pharmacist. There have been situations where people in an outpatient setting have been prescribed, say, an antidepressant by their primary care physician, and they may be prescribed something else by their psychiatrist, and the negative interaction is not caught until the pharmacy counter by the pharmacist. And I see you nodding. Yeah, that's the pharmacist is a beautiful resource. Okay. So that being said, medication, it's a day-to-day ongoing individual issue. And there's a lot of power behind it, not just by marketing, but by pharmaceutical companies, by doctors. Doctors are no longer allowed to accept Post-it notes with a medication's name on it because they thought that it may sway them toward prescribing that medication. That used to be real common, send a doctor to a conference or bring things in for the social workers at Winnebago. So for obvious reasons. So keep that in mind, okay? The biggest thing you can do is support your client in recognizing what their reality is with medications, and learning about them yourselves. Okay. One of the worst things that we can do is say to a client, well, I was on Prozac and I do really good with it. That kind of disclosure is just inappropriate. Okay. And so please don't ever bring that into the equation. Okay. Just like I would never say, well, I prefer Motrin to aspirin. Me personally, I'm allergic to aspirin. But if I'm impressionable and I want to do what you tell me to do, and I think you know better, I might take aspirin. Okay. So just keeping those things in mind. Okay. Our disclosure about our own care and about our opinions, it just really has no place. Okay. You can only support a person in their reality. If a person complains of a negative effect, it's always true until found otherwise. Okay. So I would just ask you to really keep that in mind, primary. Okay. We are almost out of time. Time goes fast. Are there any questions? If you guys want to type in questions, feel free, and I'll answer them the best I can. If I can't answer them, we'll find the answers for you. Okay. So any questions at this point? Any situations that are of concern, or?
I don't know if I'm completely in agreement on keeping all your stuff personal. I guess you could say, depending. Like, for example, I had a resident say, well, you're normal. And she was completely against the idea of having mental health issues.
Mm-hmm.
And I mean, I don't go into detail,
Mm-hmm.
but I was like, I take something.
Mm-hmm.
I struggle with anxiety too.
Mm-hmm.
So how does that make us different?
Me personally, I would phrase it differently. And I would say your reality is not the same as mine, but, don't assume that people don't understand. Their experience may be, similar to yours. I can say something like that on a general level and not say I have anxiety too. Because
Why
clients.
wouldn't you want them? I mean, they tend to appreciate that
you're able to relate to them on some level.
Yeah.
I'm going to use an example of addiction. Okay. Many times clients will think that an AODA counselor with no personal recovery history is less valid as a caregiver than one with a recovery history. The same can go for a staff that has never received psychiatric care. Okay. So automatically, by me saying to a client, well, I take an anti-anxiety agent. Okay. What is the purpose of that? You have to really look at what is the purpose of it. Does it enhance that client's care? Bottom line, really no. It's my attempt to increase my rapport or to express understanding,
Which they appreciate. So they do benefit from that because it encourages them to open up as well.
It also could be flipped though, like if I tell somebody, yeah, I was an addict and I'm 5 years sober or something like that, and then they look at me and they're like, no, they wouldn't use it against me, but I could set up an unrealistic standard for them, and they think that they have to compete with what I'm doing.
Right.
Really? I guess it would depend on the situation, but.
And, I'm a big one for why would I disclose? What is the reason for it?
Because we expect them to open up to us.
But despite us wanting to believe that we should provide care on the same plane as our client, that's not accurate. Okay. We are a provider and the client is the client. And I'm not saying to put on a different degree of importance or more or less valid, but what I'm saying is that we are there for a purpose. Okay, we are there for a purpose. Making my reality part of the client's reality is just not appropriate. Okay, we can say many people, you know, whether they're in a group home setting or an attorney, receive this type of treatment. You know, the potential to function really well is there. Okay, and you can give them hope that way without saying, I'm also treated for that condition. Does that make sense? It just, you know, you need to really keep in mind without having any kind of elitist or level type of attitude, what your role is. Okay. Just like last time we met, we talked about the role of feeling like you can be a friend to the client. It's the same principle, different content. Does that make sense? Does that make sense? Okay. So, I mean, again, it's going to be a matter of personal choice. I would caution you. I really would caution you, because that can turn on you in a dime. Okay. So, other questions?
Have you heard anything, them like cutting back on Prolixin or Haldol, like the injections, and going to something different?
Part of the problem is that the cost of Prolixin and Haldol is extremely low. Okay, in compromised populations, or that's why they are so common, because the cost is so low. Medicare, for example, will cover Prolixin often like that. When you put Abilify in the picture, which is $57 a pill, I think, they're going to be a lot more hesitant. Okay, now if there's an issue of side effects or longer term side effects, that's a different issue. Then they're going to look at the indication, but cost really does often drive those medications being prescribed.
And I have one who's been on, I think she's been on Prolixin for years, the injection, and they've switched her now to, I think it's Integra, maybe.
Okay.
And I mean, in a matter of weeks.
You notice a difference.
Oh, yeah.
Yeah.
Yeah, where it doesn't work nearly as well as.
You see Respidol often taking the place of Prolixin and Haldol as well. Respidol is really, really good for some, really not good for others. So some people just thrive on Thorazine, Haldol. There's still clients even now. When I saw Thorazine 30 years ago, there are some people still on Thorazine today that just really do well. And so we can never assume that because an antipsychotic is older, that it's not as good, but cost really is a factor. Okay, so keeping that in mind. Yeah. Other questions? Anything else? Can you make me the presenter? What is this? Other thoughts? Okay, other questions? No. I appreciate your attention and your time, and we'll see you next time for another episode.
Beautiful. I know, I can't do it online either, so I need to get it printed.
Right. Yeah.